Well, good evening. It is Tuesday, June 7th, 7:02 p.m. on the East Coast. Sorry for joining you slightly late. Although I have a feeling people are just coming in. I never know what to say right off the bat because nobody's here. So I feel like I'm like, hey, what's up? And nobody hears it. And anyway, if you're just joining us, we always like to give a couple minutes for people to get in and get settled. So if you'd like to let us know you're here, say hello, where you're from, and hey, Deirdre, it's good to see you. Hi, Robert. Let's see. Favorite song. So, we're down to one. We're having technical difficulties. I don't know if there's sun flares or what, but we're dropping like flies over here. So we're just gonna we're gonna be okay. We're gonna wing it. Hi, Sally.
Well, hello. I'm here on my phone now.
That's perfect. We lost Reid randomly, but
oh,
there he is.
Is it my turn?
Well,
disappear.
The full group is here. We are in full effect. We are excited. Okay, so if you're just joining us, we always give a couple minutes for people to get in and get settled. Let us know you're here. Say where you're from, and if you want, favorite song. What's your favorite song? We want to know. It's very important. We always like to go with something favorite. So, hey, Bonnie and Ellen and Krista and Leanne, I hope you're well. And Amanda, Lenley from California, and Bob from Portland. There's Stacy Rosenthal Young. How are you, Stacy? Good to have everybody here tonight. We have a really, really good topic along with some brilliant clinicians here to help educate us and myself. I like to consider myself an amateur expert on some things OCD. These topics are not one of them. So I will be learning right along with you and asking questions that are hopefully helpful to everyone. Wheel in the Sky is such a good song. I love that song. Good call, Deirdre. I love that song. That's on my Pandora stations. Hi, Reid. I listen to your meditations every day. Hey, Don. Good to see you. All right. So it looks like we're about 2.5 minutes over. So let's go ahead and get started. Again, apologies for our late start. We're having some technical difficulties. But we are solved. We are here and we are excited. So welcome to our town hall Metacognitive Approach to OCD Treatment and Self-Help. My name is Ethan, National Advocate for the International OCD Foundation, which, as you know, simply means I have OCD and I won't stop talking about it. So some quick housekeeping. Town hall is intended to serve as educational content and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. International OCD Foundation is not a crisis hotline. It should not be used if you are in distress or feel unsafe. If you're in a crisis or ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the Suicide Prevention Hotline at 800-273-8255. We always want to be respectful and kind of others, try to create as safe a space as possible. Remember, as you're leaving comments or questions, that this is being recorded and broadcast on multiple social platforms, and so keep that in mind. But as always, we are all here to learn and support one another and be kind and respectful and all of those good things. Before I get into it, a lot of town halls, we usually do a Q&A. We will be answering questions tonight as it relates to the specific topic above, or if you need clarification on any of these things that we're talking about, please feel free to leave your questions in the comment thread, and we will definitely address. And as always, feel free to comment and ask questions throughout, and we will be reading along with you. So with that, hey, Phyllis in Oklahoma. Hey, Shannon. Good to see you. Let's go ahead and get started. So let me introduce our panel. First, we have Dr. Sally Winston. Sally is the founder and executive director of the Anxiety and Stress Disorders Institute and co-author with Marty Seif of 4 books, including Overcoming Unwanted Intrusive Thoughts, Needing to Know for Sure, and Overcoming Anticipatory Anxiety. Educated at Cornell and the University of Illinois at Champaign-Urbana, her PsyD degree was one of the first ever awarded. Her integrative work has its roots with the pioneer Claire Weeks, who proposed an acceptance-based approach decades before ACT was developed. She maintains a therapy practice, trains clinicians, and writes a Psychology Today blog, Living with a Sticky Mind. Her work has been translated into more than a dozen languages. Well, needless to say, Sally, we are honored and privileged to have you with us.
Glad to be here. Thank you.
Yeah, absolutely. And next we have Mike Heady. I said that right? I just realized, like, I was like, oh no, is it Heady? But it's not. Mike is the co-director of the Anxiety and Stress Disorders Institute. If you were paying attention, that would mean that Mike works with Sally. So there you go. Mike is a licensed clinical professional counselor who co-directs the Anxiety and Stress Disorders Institute. He's been specializing in treatment of anxiety disorders and OCD for 15 years. As a faculty member with the IOCDF's Training Institute, he provides training webinars and consultation groups for clinicians and regularly presents clinical workshops for regional and national organizations on the subject of anxiety disorders and OCD. He has a special interest in the metacognitive approaches to OCD treatment. Mike, you've been a guest before. Thank you so much for joining.
Glad to be back.
We're glad to have you back. Last but not least, we have Dr. Reid Wilson. Dr. Wilson has spent his entire 30-year career, so clearly he started practicing when he was 4 years old, in the field of self-help for anxiety disorders and OCD, including authoring 6 books. With Dr. Edna Foa, he co-authored Stop Obsessing, the first ever self-help book on exposure and response prevention. He directs the longest-running free anxiety self-help site on the internet called anxieties.com. In 2019, he received the Patricia Perkins Award by the International OCD Foundation. And this January, he released his 4-hour online self-help course called OCD and the 6-Moment Game, Strategies and Tactics. We will talk more about that later on, as always. And also, Skyla has posted a link to that in the comment thread. Dr. Reid Wilson, thank you so much for joining us.
Glad to be here again.
All right, so let's dive in. I guess let's start with a very basic question, which is, I think, a fair question as well. What is metacognitive therapy approach? What is metacognitions? What is it? I think maybe let's go in a circle, and let's start with Reid and work our way around. I know it's a big question, so maybe we can each take a piece of that.
Well, sure. Adrian Wells, I think, wrote the first book called Metacognitive Therapy of Depression and Anxiety. Prior to his work, really, metacognitions were studied and have been studied for decades with young students. And metacognition, we're thinking about really going up. And that's what we want to be paying attention to. And so with young students, what they're trying to teach them is how to learn, and they have to get off of the subject matter to get up to the level of how do I learn, how do I retain information, what are my strategies and so forth, so that these kids can operate independently, no instructions, no guidance, they can run it themselves. We think about metacognitions in this kind of way, which is that we want to be able to learn it in such a way that we can transfer it from one arena to another arena. We get off content and onto process is a simple way to be saying what we're doing here.
Okay. Dr. Winston,
Just a very, very basic, go all the way back to the beginning. Metacognition means thinking about thinking. And metacognitive therapy is therapy that approaches at a higher level than the content of thoughts. It's thinking about the process of how thoughts work. The other piece of it is that in metacognitive work, we're not just actually talking about thinking, we're talking about thinking and feeling about thinking and feeling. So it's my first introduction to metacognitive issues was reading Claire Weekes in the 1970s, in which she started to talk about panic disorder in a completely different way. What she identified something called first fear and second fear. First fear was what your body and mind did instantly in reaction to a trigger. And second fear was what you made of it, how you reacted to it, how you responded to it, how you thought about it, how you evaluated it. So for the first time for me, I recognized that there were two levels to things. There was the level of the immediate, what is the thought, what is the feeling, and then there was the second level, which is what do you make of it, how do you react to it. So metacognitive therapy is really not about the thoughts and the feelings. It's about the thoughts and the feelings about the thoughts and the feelings and how that process works. Is that all clear?
I think that was clear, and also not clear in the sense that it's heady, not to be confused with Mike, but it's definitely interesting, and I think so. No, it made perfect sense, and
well, let me put it in a even more Weeksian way. How she defined an obsession was a stuck thought in a tired mind. She wasn't the least bit interested in what is the thought about. She was interested in how does the thought feel, what's its context, how does the thought behave, and how do you react to it? That's when you're focusing on metacognition. That's what you're focusing on, not what is the thought about.
And that makes a lot of sense, and I appreciate that analogy. It's really good, and I think that even exposure response prevention, we learn early on that OCD is OCD and thoughts are thoughts. So it's like taking that the step further and really basing an approach to treatment and looking at how you see, well, in this case, OCD, and again, moving away from the content, which we can get so wrapped up in as individuals with OCD, and really look at the processes around, I think is really, really interesting, and I'm excited to hear more. Mike, same question. I think Reid and Sally have both taken a crack at it, but what is your approach?
I'd say it's virtually the same, right? I think we're all using different language to describe the same process. I think of meta as awareness of process, metacognition, awareness of thinking and reasoning processes. I like the stuck thought in the tired mind, right? It doesn't matter what the thought is about. It's why it got stuck, how it got stuck. Can we get it unstuck? And the only thing I think I can add that might be slightly different is just to bring it a little bit further into the treatment perspective, which is that the target of a metacognitive approach is the cognitive shifting itself. It's to learn how a thought got stuck, how an obsession became constructed, believed, trusted, and that's the direct effort of the treatment. So whereas we might look at more ERP as getting at that incidentally or indirectly, metacognitive approaches are deliberately going after that cognitive shift. So that's the thing I think would make this, in contrast to behavioral models.
What Adrian Wells said at the very beginning, and what he has really locked down into place, is that the metacognitions, what he pays attention to is that people believe in the importance of the message, and everything else filters down from that. Perfectionism and over responsibility and everything is all about the message is so believably important. And if we can't change that, then it's very difficult to change everything else. It will really drive the bus if we don't make a shift at that point. And that is a hard sell. Often I talk about this as persuasive therapy, because this disorder comes in and just delivers some very powerful messages that are frightening, and some solutions to it that seem to be working. And who wants to change when their solution is working pretty well and the alternative is to release that? That's frightening for people. So that's part of what I hope we will talk about as the night goes on.
I think the other piece of it is, of course, that when you're anxious, or when you have OCD and you're particularly sticky, the way that your mind works changes. And when you're stuck in obsessional doubting, you don't experience your relationship to your thinking in the same way. When you're not particularly anxious, you can have thoughts that just seem silly and you don't care about them and they go away. When you're anxious or you're worried about a particular class of thoughts or a kind of thought or an experience that you're having inside your mind, then the way that you process that thought is significantly different. And you make thinking mistakes when you're anxious like that you don't make when you're not having whether you call it an OCD attack or an obsessional doubting attack or whatever. Your mind works differently. You evaluate danger differently or risk. Your senses are heightened. Your ability to become engrossed in or hijacked by your imagination is amped up enormously. So you build stories about your thoughts, and then you believe your thoughts, and you buy into stuff that you wouldn't buy into if you weren't anxious or if you didn't have that relationship to your thoughts where you're just immersed in them. So it's also taking a look at the way that your mind functions when you're stuck in obsessional doubt or anxiety state.
It makes a lot of sense because, to your point, objectivity and insight drops dramatically when you're in that state. So you have very little. It's really difficult to make insightful and decisions that aren't cognitively distorted.
And I think I would just add to what Sally's saying. All that Sally said is we need to embed that into the client. We as therapists know about all of that, but it's the client that needs to receive that information and metabolize it and make it their own. Because if we don't want someone to simply be following the instructions of some technique or an exercise, we want them to metabolize in that way. So everything that Sally's saying is we need a delivery system that competes with the delivery system of the disorder.
Is this a shift in treatment for OCD?
Well, I don't.
Well, Reid's been doing this for the last 35 years, so I don't know if it's a shift for Reid. I think a lot of us have done metacognitive work in one way or another over the years. But this, for many people who haven't been introduced to metacognitive work, it's going to be a big shift because some of the ways of going about the work are really quite different. Mike, you want to say something about that?
Sure. I think it is going to be different for the large majority of people being trained in more traditional treatments. So like ERP and traditional training institutions, they don't do a lot of work at the metacognitive level, right? They do a ton of work at the behavioral level. And so this, I think, would be a shift. And there are some schools, if you will. Inference-based therapy is one of them out of Montreal, Metacognitive Therapy out of the UK, that actually have sort of a protocol on how to do metacognitive work. Reid's 6-moment game isn't a protocol, but I think it does follow a sequence. And as do all of these processes where the exposure or the behavioral experiments might not be at the forefront. They might be used to facilitate other kinds of learning or not used at all, or not necessarily needed to be used in the case of inference-based therapy. I'm happy to unpack any of that. But yeah, I do think it's going to be a big shift, at least in the United States. I don't know that it's as much of a shift abroad.
Well, the other shift, it's even a shift away from cognitive therapy, because cognitive therapy is talking about content, the exaggerated thinking, black or white thinking, all or nothing, that whole list that we have is typically responding to the content itself. And again, we want to go up instead of get into that content. But the other way to think about, I think, metacognitive therapy is that it augments the stuff that we're already doing. It's additive, and the biggest place that I think it's additive is that it can motivate the client more. It can get them to be more determined. If I buy into and understand the protocol that I need to push through, and then I understand that I need to get determined about all of this, then I become more of a equal collaborator with the therapist. I think this is a self-help approach, period, and more than a treatment approach. And I think all treatment is self-help. So, I mean, who am I to talk about that? So I do think it doesn't have to be, it's this versus that. But for people who are already doing CBT or ERP, this can help strengthen the work that they're doing.
Can we talk a little bit about how?
Sure. When would you like?
The first thing that I just want to emphasize something that Reid just said, which is he used the word technique. And I have a lot of trouble with methods that are applied techniques, where a person is told to do something to change what they're thinking to something else, or to if they're tense, to relax, or if they have a technique to apply. Because I think what often happens is, without a shift in your relationship with your experience, people, without an acceptance of the experience you're having, not as something that needs to be fixed, but that your relationship needs to change. Without that shift in your relationship with your experience, then people tend to bravely force themselves out of willpower and sometimes great bravery and effort to push themselves towards whatever they're scared of. And that results in something which everybody knows as white knuckling. And it's not a good experience. And what you learn is doing this thing is pretty awful. And it doesn't actually change your experience at all. What you learn is that you can do it, but that you're miserable doing it. And so when you say, how do you do metacognitive therapy? The first thing I want to say is it's about an attitude and perspective shift. It's not about the application of a set of techniques. And that's just, sort of fundamental to it. And Mike, take it away.
No, yeah, I obviously echo everything you say. I think we want our clients to kind of co-discover, if you will, that their obsessional narrative, the thing they've been immersed in, transported by, absorbed into, is a bad dream, is something they can wake up from, is a series of processes that led them into that place that got them immersed and absorbed, that can in fact be changed. We can relate to it differently. We can challenge and address a reasoning process, depending from how you want to work on this. ACT does some of this, Claire Weeks was doing this, Reid does this, and so do the other more structured metacognitive approaches are trying to get at that same thing. And to bounce back to something Reid had said, these are absolutely complementary and in no way attempting to dethrone or displace ERP, but to add alternatives, even if they aren't being used concurrently. So again, if I'm speaking primarily on behalf of inference-based therapy, it is actually an evidence-based therapy that doesn't require behavioral experiments or exposures. It is an entirely metacognitive approach that once the person, if I can be poetic one more time, wakes up from that obsessional narrative and realizes what it is, the rest of what was occurring, the fear about the consequence of the obsession being true falls away because it was just a dream. The response with a compulsion or avoidance falls away because there's no need to do it because it was false. It was a dream. It was imagined. And so we can use this concurrently, like to beef up ERP, to help out where ERP is stuck. It's completely complementary. Or in some cases can be used without the use of ERP or behavioral experiments, which I know is a bit of a controversial thing to say out loud in public, but
well, one of the things that all clinicians find out is that you can construct a hierarchy very specifically about the things that a person might need to confront in order to bust their obsessional doubt or to approach whatever they're afraid of, and that there's often a moment of aha somewhere along the line in which the person goes, oh, it's not the place, it's the thought, or, oh, I'm responding to stuff I just made up, or, oh, my heart beating and my body feeling like it has to run doesn't mean danger, or some kind of huge change in how they interpret their experience. And then the whole hierarchy that you had planned meticulously collapses like a house of cards because it's completely unnecessary because they get it. And
how did they get it? Because they did exposure work. Experience is the greatest teacher, right? We get a sense of what we're going to go after, and then they step in there and do it. The way that they get the aha is that, right? They do an experiment and they go, oh, it didn't turn out like I thought it did. I mean, I'm embellishing what you said. I hope that I'm saying that right, Sally.
Mm-hmm. And I think sometimes if you're able to work with someone to understand how the thoughts got stuck in the first place, you may not even need to go up that hierarchy at all because they're able to see what they did, the sort of mistakes they made in assuming that the thing that they're afraid of is actually something they should be afraid of. Thoughts are not danger signals. They're not red flags. They're not warnings. They can't move things in the world. They can't make things happen. And people have all kinds of beliefs about thoughts, beliefs about worries, beliefs about what it means to worry or why I'm worrying or why this thought occurred to me. And all of those beliefs together can make a person stuck in an obsessional universe in which their only choice is to avoid or to compulse. And if you can actually convince someone that this thing that they're scared of is not something they need to be scared of, then most of their ways of trying to get away from it fall away. And some of the metacognitive work can get you there.
I would love to do something different in this particular town hall because I think it would be helpful because we're getting a lot of great comments and questions, and I know I'm interested. So I'm going to use myself as a guinea pig. I would love to do, if you will, if y'all are up to it, and we'll get to more questions, a 4-way role play, if you will, because I think that would be really helpful. So as someone who is extremely sick and bedridden with OCD and went to therapy after 17 years of being diagnosed with OCD, but getting the improper treatment, I was extremely resistant to ERP. I found it extremely hard. I didn't think that it worked for a year or so until lots of interventions and ACT came into play, and I suddenly started to see thoughts from an objective perspective and completely get a different relationship with my thoughts. And once I had a different relationship with my thoughts, then I could really integrate ERP in a really effective way, right? So there's like little bits that you're talking about that I resonate with me in terms of my experience with ACT and DBT. Of course, you're talking about metacognitive, and it's this idea. I'm having like all of these realizations, like, okay, you're saying that, like, in some respects, ERP treats the root In other respects, it misses the root, it's symptom. And if we get a little higher, we hit the root cause of the issue, right? With the metacognitive approach. And so we're not just cutting the hair, we're pulling it out at the root so it doesn't grow back, kind of thing. Maybe that's a weird analogy, or maybe that's accurate. Maybe it grows back a little bit, more like laser hair removal. It goes away for a period of time.
Maybe we'll just kill off that idea altogether. Yeah.
Okay. Appreciate it. Thank you for the support. But anyway, but I think I would love to see an example. I would like to come to you three with the way I presented, and I would love to have you all respond in a metacognitive approach, so we can give a real world example for a lot of the folks that are wanting to hear how this relates in sort of a real world experience. Is that okay with everybody?
We'll see.
We could try.
So I'm going to literally use my own example from when I came in on the first day right out of a psychiatric hospital. I was deathly afraid of accidentally hitting my head and with my fists and bashing my head in and causing a brain bleed. That was my fear. I walked in the office. I had my thumbs in my belt loops because I felt like that protected me, because if my hands were tied up, then I wasn't going to do it. What if I accidentally hit my head when I wasn't paying attention and caused a bleed? What if I just start uncontrollably bashing my head? On day one, I had to make a list of, actually, no, I didn't. I had to make a number 1 to 100 and leave blanks. And then we ran around the office and I hit my head on 100 different things. And I had to write down what I hit my head on and so forth and so on. If I came to you, how would you dissect this from a metacognitive approach?
Well, I think we'd start with the story that you just unpacked for us. I would say, why don't you tell me a little bit more about the story that brought you into that place? You first mentioned that you were terrified that you were going to be bashing your head in, with your hands, right? So if you could take yourself back to that moment, I'm guessing there's a part of you that wasn't thinking that you were going to bash your head in 24 hours a day, 7 days a week, but there was a moment where that what if got provoked. Can you take yourself back to that moment?
Yeah.
For just a minute. Can you find out right before that what if occurred, what happened? Were you watching something, thinking about something? What was going on for you?
I was in bed and I was struggling already, and I'd actually been to a psychologist that was assessing me for suicidal ideation and said to me, "What if you impulsively hurt yourself? Are you at a risk of doing that?" And I replied, "No, that's ridiculous. I wouldn't accidentally." And then I got in the car and thought, "Oh my God, what if I accidentally hurt myself?" One more thing. The next day, I jumped into bed and I hit my head on the back of the wall. And I immediately went, "Oh my God, what if I have a bleed?" And I got really scared about hitting my head. And within an instant, it was like, "Oh my gosh, what if I hit my own head?" And that was the moment where I dove into that dark space that brought me down.
Yeah. So what I'd want to try to point out is to try to demystify this whole thing real quick and just demonstrate that it follows a pretty standard sequence. It follows almost a formula, the way all OCD tends to follow a bit of a formula, where, it begins with a doubt, a what if, a could be, a possible state of affairs, if you will. And what happened for you as you described it was you had been asked, what if you lost control and started to hit yourself? Are you at risk of hurting or killing yourself? And in this moment, that was what we might call a prompt or a trigger. And it elicited a what if thought, otherwise known as a doubting statement, a possibility. And from this point, you said, what if I could do that? What if that's something I would do? And then you said something else quite interesting, which is, I know I don't want to do that. No. So in that moment, you actually knew something about yourself. You had evidence, you had some awareness of something that was true about you, and then you doubted it, right? And this is an important part of the sequence. We have the prompt, we have the what if. The what if is always a doubt about what you've already known to be true about yourself, which is, I don't want to hurt myself and kill myself, but what if I do? And then that thought through a series of very clever and convincing tricks and rhetorical devices, caused you to become immersed and absorbed in that story. And then you got caught up in the consequences. Well, if I did want to do that, then I would be a danger to myself and I could end up injured or dead. And if that's the case, then I feel panicked. I feel terrified. So I need to do something about this. In which case, you then found yourself to the end of this sequence, which is the compulsion, where you were kind of tying your hands up in your pants so that you didn't do this. And so one of the first interventions from, and this is an inference-based model here, is to sequence out and demystify the OCD process and help everyone understand that this actually began with a doubt that I'm not particularly concerned with the content. What if I killed myself? What if I hit myself? What if I beat myself to death with my own hands? I'm really interested moving forward in what it was that got you to buy into or trust that what if thought instead of what you already knew in that moment, which is that I don't want to do this, but what if I do? There's a processing there, a metacognitive process that we can adjust and we can change. Now, I'm not going to go through 12 to 14 sessions of treatment, but that's how I would initially.
I was going to get such a great deal on it too. Damn. No, but go ahead, Mike, please. Yeah, go ahead, Sally.
So taking it from there, because Mike and I operate quite similarly, although I don't necessarily follow the IBT protocol, what I would also do is a little bit of teaching about stuck thoughts. That clearly you have a stuck thought, and the stuck thought is, what if I hurt myself inadvertently and against my wishes? Oh no, that's the stuck thought. And then what I would say is, how do thoughts get stuck? And how thoughts get stuck is by the amount of energy and fuel you give it by trying to keep it from coming. The more that you struggle with a thought, the more stuck it gets. That's the fuel that keeps thoughts coming. The same one over and over again, or variations of one, all on the theme of what if against my wishes, I hurt myself accidentally, or even what if I intentionally hurt myself? Oh my God, that's the stuck thought. It gets stuck because you don't want it in your head. It's the struggle against it that makes it stickier and stickier and stickier by virtue of a process called negative reinforcement. The more that you struggle against it, the more it occurs. So what we know is that that's what makes thought stick. Now, why that thought? Which is always the next question. And it's the thought you most don't want. So it's the thought that's the opposite of what you value or what's important to you. So what we know is that people who have stuck violent thoughts are people for whom violent thoughts are what they definitely do not want to have in their head.
The ego dystonic,
so
sure.
Violent thought, OCD, is always in people who value gentleness, who are gentle people, who are not violent people. If you had a violent thought and it didn't bother you, it wouldn't get stuck. In the same way as if you are a religious person and you have a blasphemous thought, you might struggle against it. You're not going to have an atheist with a blasphemous thought stuck because they don't care. So what is so important to know about this thought and any stuck thought is that it's not what it seems. It's the opposite of you. It's not a wish. It's not an unconscious urge. It's not something that you have to guard against or keep from happening. And in fact, as Mike said, it's not what you want, but it's not dangerous to leave it alone. And that's the key. It's
Reid,
not dangerous to not try to make it go away.
Thank you, Sally. And thank you, Mike. I think this is really helpful for the non-clinicians that are in the room that kind of want to understand it from a less clinical perspective, although everybody was making so much sense. And I think My next question, Reid, is that does someone have to be in the right mindset to be able to absorb this information and look at it from this perspective? So what I'm thinking immediately, and obviously everybody's at a different place in their own journey with different severity levels and things like that. But as Mike was talking, I was thinking back, if he had been talking to me on the first day, I would have been interrupting him over and over again, going, yeah, but what if I do it? Yeah, but what if I hurt my head? Okay, you're not listening to me. I'm going to hurt myself and I'm a danger and I don't want to, but I understand what you're saying, but that's not my situation. Like, how does, and this is where you're saying I think this is where you're saying, I don't want to put words in your mouth, but metacognitive therapy is really a wonderful additive to all of the tools and things that you have at your disposal to treat that. But do you have to be in a certain place to be able to absorb and ingest this information to start wrap your mind around this? Or if your overvalued ideation, your belief in your OCD thoughts is so high, how do you break through that with metacognitive? Is metacognitive a good approach to do that with, or is there other modalities of treatment?
I think absolutely you have to be in a particular mindset to absorb what we're saying. Absolutely. But that's part of my job as your therapist, to help you get there. I am not going to fight you about this. If you think, hey, I could do this. I don't, this isn't OCD. This is serious. I could do this. Well, okay. So why are you talking to me? I mean, I would have to challenge you around that. So at some level, this isn't working not right with you. I am very aggressive in my work. I'm going to be one down with people because I don't know them yet, but I'm going to be pretty aggressive around, look, I know this disorder like the back of my hand, and I don't know you, so we'll have to work together. But let me say again, this is a delivery system that is a content delivery system, and it's one up and comes down. We cannot work on specific. We have to go up to the level of the disorder. So what I want to work on you about is, this is a mental health disorder. It's a mental health disorder. You have to understand that. We got to treat the disorder. It's a highly aggressive, creative disorder. And if we don't rise to the occasion and bring as much strength and power to it as it has been bringing to you, you're going to have a hard time winning. So that's what we want to turn around. And the first thing that we're doing here is to degrade the topic. You have to degrade it. It needs to be seen as noise, as nothing. I don't need, if it was important, I need to pay attention to it. We need you to buy into the idea that it is unimportant. And early on, we're going to have to do probably some experiments around that to help you understand that. But until we get there, I want you to know this is an attitude, and it's an attitude of determination. It requires trust. You cannot trust the mind that you have right now when you're activated by the disorder. You can't trust it. And that's a big sell. So I do want my client to understand, I want them to think I'm the greatest thing since sliced bread, because I'm going to give all that power back to them. But I have to be equal to that disorder. So we do need to work on the mindset, and as many clever and, interesting ways for us to go at it. I think we've all been at it long enough that we have our own little ways to get there. So that's where I would start. And, until we get what you're talking about, Ethan, until we get that, where, okay, I'm going to try what you're saying. I mean, that's where we have to get to. And I'm going to see what I can do to go after, the first assignment, and many assignments that I would say when I'm supervising clinicians is how do we work in the session together? So by the end of the session, we've collaborated with some kind of experiment in which they will generate some degree of uncertainty and distress about their theme. And that's where we want to start working.
And that's basically to your point, the subtypes and symptoms, if you will, are a distraction of the disorder itself, which is what you're targeting at this point.
You got it.
If I
Understood.
can,
Yeah, please, Mike, weigh in.
just a real brief comment I want to make about the the role play too, which is that I'm not here to provide you with an experience. I'm here to co-facilitate the guidance of that experience. So when I'm walking you through your story, it's your story to tell, right? This is the first time you and I are meeting. I'm trying to understand your distress. I'm trying to understand and empathize what it was about this that so convinced you, that so transported you, and have you explain to me what that was, what got you hooked. I want to know that, because all of that is going to be grist for the therapy mill from a metacognitive approach, because from my vantage point, I'm trying to help you see this as a narrative, as a story, a construction. It's not a thing that happened to you. It's a thing that was constructed from within you and then got you so hoodwinked and conned. And to see if we can step outside of that and see that process for what it was, right? Which is a giant trick.
Yeah, it's really important that you understand that the story that you made up, which is, I could do this to myself, what's stopping me? Oh my God, I'd better stop myself from hitting my head by holding my hands a certain way. That once you're inside that story, it seems logical from the inside. Well, of course, if you really were in the grip of an urge to bang yourself on the head, actually holding onto your belt loops sounds pretty logical. The problem is it's all logic within your imagination. This hasn't actually happened. You made it up. And so you have to step outside and see that before you can let go of what seems like a perfectly reasonable response, but it's a story you made up. And
I think this is.
Go ahead.
No, go ahead, Sally, please.
No, I'll go ahead. So, what's part of what Sally's saying, it's within that frame of reference, what you're doing makes sense. If you have, if you have psychosis and you think you're Jesus Christ, you probably think you're a pretty good carpenter. And I mean, it's just, and so until you can step out of that frame of reference, and part of what we're doing with metacognitive therapy is it's one big step. It's not a bunch of little steps. It's one big step, which is, this is the perspective that you've been dished out by the disorder. We have a competing point of view that we want you to step into. And if you will run out of this point of view, you can get stronger.
I'm kind of having a mind-blowing experience right now as I think back on my journey during my 1.5-year tumultuous descent into darkness and back out through a variety of modalities of treatment. And, Sally really struck me. I think that as I talk with the OCD community, and you all obviously interface with all your clients, white knuckling is such a huge part of it. We always feel that ERP is failing us, but many times or ERP doesn't work for us, but many times it's how we're approaching ERP. But at the same time, I think about what you're saying now. It's like, gosh, if I'd have had that insight while I was doing ERP, then that would have made a lot of sense. Because I was I know is what you're talking about. So it just like hit me because I was so laser focused on this one thought and this one piece of content and what is the exposure around that content and the thought. And for me, the groundbreaking moment and shift that I had is when I stopped doing ERP and dove headfirst, no pun intended, into ACT. And once I started working on ACT specifically and engaging in my life, and people know my story or they don't, but regardless, soon as I understood a better relationship with my thoughts and how I was interacting with my thoughts, and even got further educated into OCD, and that the content, the OCD tornado was just that, is a tornado. The content was irrelevant. It was the same tornado. Once I was able to glean some of those things, ERP started to make a lot of sense to me. And I stopped white knuckling and started embracing. And at a certain point, to all of your points, I saw the matrix, right? I saw the green code and I went, oh, this is all BS. Like the whole thing is BS. So it's clicking for me how it all integrates. And so Dr. Winston, when you talked about white knuckling, it really spoke to me, as I'm sure it speaks to a lot of people, in the sense that, you spend years not really understanding why you're doing this. Okay, I have to accept uncertainty, but I do and I don't. But it's like to sit there and simultaneously readjust your perspective, So it's being an astronaut. It's like inside of the Earth, you can't see what the Earth looks like. But once you're at the space station, you're like, oh, that's what I'm inside. I can have an objective, observational point of view and attack it from as such. Makes a lot of sense.
Yeah, and I would just say, Ethan, that insight, when you have that insight, it does not make your work easier. It makes it more effective. You're manifesting the work that you're going to be able to integrate and have, insight and growth all down the path. So I don't want us to, make people think that, do this work and everything will be easier for you. Still a very, very difficult disorder and has to be handled in a powerful way.
So from a clinical perspective, Sally or Mike, how does, I just made it up, but how does metacognitive therapy work in conjunction with ERP? When you see an individual with OCD, how do the two interrelate? When do you introduce what? How are things? Go ahead, Sally.
From my perspective, and the exposure part of the work is pretty far into the process. I'm going to spend a lot of time with someone before. Then this is different from Reid. I'm going to spend a lot of time talking about how you got to where you are, what the processes are, what a thought or a doubt, what an obsessional doubt is, how that's different from an ordinary doubt, what uncertainty is and isn't. Of course, accepting all uncertainty is not part of this picture. I'm going to spend a lot of time until until the person that I'm talking to has grasped at least some way of understanding why to do exposure, and that the exposure is part of a willingness to trust that what I'm saying is the reality you want to be in, not the one that the OCD is telling you. Mm-hmm. And so the ERP comes, the exposure, it's not really ERP, it's mostly RP. But the part where you're deliberately going out and exposing yourself to stuff, or you're thinking thoughts on purpose, or you're greeting thoughts that happen to cross your mind in a different way, those exposure-based things come and look quite far into the process. And very often they're, rather than being an extracted hierarchy from the beginning, it sort of emerges organically out of the discussions that you're having. And the patient will often assign for themselves a behavioral experiment or an exposure, or I'm going to try that, or, oh, I see, I don't have to be worried about this or that, and proceed towards challenging themselves once they fully understand what we're talking. And it's not 100%, but understand enough that they're actually surrendering towards the things that they're scared of themselves. It's less assignment by me and more self-assignment, because it just starts to lay itself out.
Sally, I just got to pick up on what you just said, because you kind of pulled back once they fully understand. Well, not fully understand. And that's just it, right? Because you can't you can have somebody be certain, right? Because exactly. This is a disorder of uncertainty. So I like that clarification that you made around, well, you understand it enough to begin to mess with it.
Right, exactly. That couldn't have been better said.
I'm reading some of the community conversation in the thread, and it's interesting because obviously within the OCD community of lived experience, there's a lot of divisiveness around whether the content is or isn't important. Not so much from a clinical treatment perspective, but from how you identify within the community perspective. And then there are a lot of folks that deal with subtypes and symptoms that are more taboo, and violent, sexual, intrusive, pedophilia, harm, things like that, where they feel even more stigmatized. And so, some people within the community, within the those with lived experience, feel very strongly that, well, my subtypes and symptoms are really important because that's how I connect with other people. That's how I define my OCD. And other people are like, no, it's content. Content is thoughts or thoughts. How do you introduce a metacognitive approach? And I think somebody actually left a comment about that.
All those POCD people have something in common. They all do. They all love children and find the idea of hurting a child the most horrible thing they could think of. So yes, there's great community among people who got stuck on certain topic areas. But these are not urges. They're stuck thoughts. It's an entirely different thing. So what I like to say, the way I like to put it is, the content is meaningless, but it's not random. It's not random. It's picked by the themes that are the most opposite of you. They are the most opposite of what you know about yourself in a common sense, wise mind kind of way. What you know about yourself is that you love kids, and that idea is horrible. And that's something you know about yourself, and you up until you got stuck on that thought, you never really thought about it. Now that you're stuck on the thought, it's a thing. And yes, people with POCD do have something in common, but it's not random.
Well, that's why I really like this. That's why I really like this conversation, is because it eliminates the divisiveness where individuals with OCD have against one another, where it's all content based, and my theme is worse than your theme, my theme is more taboo than your theme. It's all OCD. We're all going to the same conference. We're not going to the POCD conference and the HOCD conference. It's, and I think that's where it's really beneficial to really hit on this idea of, the content is. So Mike, it was thank you, Sally. I really appreciate that. I love the way you explain. Your analogies are really good. I was going to make a joke about Reid, but sometimes he scares me in his reaction, so I'm not going to do that. Mike, so how do you validate? I think Sally actually demonstrated how she would have done it already just in her explanation, but just to take it a step further, when somebody feels really attached from an identity perspective to their theme, how do you get into this methodology of, the content is irrelevant, but still validate and have compassion around what they're experiencing in terms of their content?
Well, I mean, not to put too fine a point on it, but I think you just described it. Our clients need to be heard and not dismissed. And when they're telling us why they're suffering, we don't want to go, yeah, content doesn't matter. Go ahead and stop telling me that story now, because content doesn't matter, right? We can get lost inside of our own models as therapists sometimes and forget that the client's coming to us with their own idiosyncratic suffering. And they need to be heard, and they need to be felt like we understand them. And I think they need to be able to tell us what it was that convinced them of this. And that we get that that's why you got convinced, and we're not dismissing that. So when we're talking about taboo themes of OCD, I think we have an opportunity to validate and to be compassionate with our clients by hearing their story in all of its detail, and understanding why they're suffering, and also give them an opportunity to explain what it was that convinced them so. And then from there we can build, at least from the way I practice, help them build an understanding of how all of this was a constructed, imagined narrative. But that's kind of down the way. I think there's no reason to dismiss the content, but I agree the content in treatment is a foil. right? It's a thing I use to demonstrate how you got tricked, but I'm not trying to change the story or the content of your story. I'm not trying to dispute it, to refute it, to test its anything. I'm trying to go, well, that story is convincing to you, just like Sally said, because it's literally the opposite of what you know yourself to be, and it's the thing you fear being the most, right? And so that's why you're monitoring for it. And someone in the chat had asked a question, about intrusions versus inferences. And this
I
is
was just about to ask you that question. Yeah, go ahead, Mike.
It's a much longer conversation than we probably have time for today, but intrusions and inferences. This is one of the separation points between traditional cognitive behavioral therapy's understanding of how an obsession comes to be. That it is a normal occurring intrusive thought that becomes so scary to the person that they appraise it negatively, and then they start getting lost inside of it and fighting against it. As Sally said, these aren't random thoughts. These are selective. They're selective and idiosyncratic to you and what you care about and what you're afraid of becoming or what you're afraid you might secretly be. That's not random. So from an inference-based therapy perspective, if you already have this feared sense of self, what if I'm the kind of person who could lose control and hurt kids? That you're kind of in a state of surveillance for anything that might confirm that. And then if you come across anything, like I happened to look at a kid as they're playing on the soccer field the other day. Ooh, does that mean I'm a pedophile? There was a covert surveillance for anything that might push the button. What if I'm a pedophile? Could I be a person that harms kids? So this is actually, from the IBT perspective, an inference. That thought showed up and you had an inference about that thought, an inductive reasoning error, as it turns out. So it's not a random intrusion that happened to be scary to you. This was a selected thought that was about your most vulnerable self. By vulnerable, I mean the unwanted self, the feared self, the opposite of who you actually are, but what if I could become self? And what bubbles up from that is a covert surveillance for anything that sort of pushes that button. So that's, if I can make that in like shortest explanation possible, that's a difference between an intrusion in a traditional CBT, which is these are normal random thoughts that happen to be negatively appraised, versus these aren't random thoughts. They were selected for. You don't get obsessions about all scary thoughts. You get obsessions about a thematic set of scary thoughts and where'd that theme come from. Now the theme, again, the content is understandably irrelevant from a treatment perspective, but it does help us point to what your feared self is. And I can unpack that more, but I'll leave it there just for brevity.
I appreciate it, Mike. Quick question, because we've talked about inference based CBT as a metacognitive approach, just to help folks and myself understand it more. Metacognitive is the umbrella of treatment, and then inference is underneath that umbrella. Would that be fair to state?
Sure. Yeah. From that would be a fair statement. So metacognitive could include metacognitive therapy from Adrian Wells. It could include inference-based cognitive behavior therapy, perhaps even ACT, although they would consider themselves a behavior therapy. And of course, mindfulness-based cognitive therapy for OCD, in fact, would be a kind of metacognitive therapy. And then, what Sally and Reid do, which is not like a codified thing. It's like they do Reid and they do Sally, and no one else can do Reid and Sally as well as Reid and Sally can do Reid and Sally. But they're,
and I can't do Reid.
Yeah, well, no one can do Reid, but right. But yeah, I think that's a fair assessment. Just like you could make the argument that there's third wave CBTs, and underneath third wave CBTs is ACT and DBT. Metacognitive would include ICBT.
And that's what I just wanted to, because we were talking about, there's a metacognitive approach to OCD, and then you're talking inference. So I wanted to make sure that people understood that inference was a part of the metacognitive, and that metacognitive wasn't some separate modality of treatment. Go ahead.
I would say there's there's a lot of separation and differences between the approaches, but the fundamental focus is the same. These are processed, focused therapies. This is not content-focused therapy. This is not disputation and reputation of a story. This is all process-focused work. And if you're doing process-focused work, then you're doing metacognitive work.
Gotcha. Reid, can you tell us a little bit
It's
about your... Go ahead, Sally. Go ahead,
go
please.
ahead.
No,
I
get
was just
Reid.
adding to what Mike said. It's about perspective. It's about attitude. It's about pattern. It's about process. It's not about content. And all of us are interested in having people learn a set of principles or way to understand the way their mind works so they can take off from there. And that's where the self-help piece comes in, because it's you don't want to play whack-a-mole with OCD where every time it comes up again, it's a new thing and now you have to go back to therapy. You have to have an overall perspective on it that you've learned and incorporated and understand, which you then just apply when OCD comes back trying to get you again.
Yes. I was thinking, you know, so Reid, would you not consider ERP as self-help?
You can make it into a self-help, sure.
I mean, in the sense that, you know, while you may need support creating a, you know, behavioral program or whatever, you know, you can take the presets of what you learned, and as themes and subtypes morph and shift, you can apply what you've learned and create new exposures for yourself to be able to deal with those symptoms and subtypes.
Yeah, I mean, all of us who have a specialty in OCD want to pass all this stuff on. And so when treatment is over, and if you have another brush with a new, you know, obsession, we don't want you to have to come back into treatment every time that happens. We want to have you embed the principles, as Sally was saying, of treatment so that you know it. And if things show up again, then you can brush off your skills and go back to work and apply those things. So whatever form of treatment we're using, it needs to end up being a self-help protocol.
I'm going to toss out a supposition that I could be completely off basis, but as I've never treated, I'm not a clinician, I don't treat, but you all three have treated for many years in a variety of modalities. I would wonder, is there a lot of intrigue and willingness when you engage an individual with OCD in a metacognitive approach, more so than in a behavioral approach? And the reason I ask that is because as someone with OCD and someone who's spent a lot of time with folks with OCD, we love being smart and we love figuring things out and we love deep diving and really dissecting and talking and figuring out. And although that can become compulsive, I would imagine that in some ways, looking at this story and the idea of the thoughts behind the thoughts would be pretty intriguing to someone who kind of wants to figure out their OCD, which is illogical. But the idea of turning that curiosity into something like metacognitive would be, I think, exciting isn't the right word, but is there a lot more curiosity that you find as you approach individuals with OCD with the metacognitive approach?
Well, you know, my second career was in chronic pain patients, and my dissertation was on chronic pain. And the trouble you have treating somebody with chronic pain with psychological interventions is they feel like you don't believe my pain to be real. So the curiosity and intrigue and so forth does come eventually, but really up front it is, I mean, a lot of what Mike was saying and presenting is like, and what you were saying, Ethan, no, you don't understand. No, this is what I experience is real. I have to take this seriously. So until we can get that accomplished, where we're all talking on the same page about what needs to happen. Once that happens, and part of what Sally was saying is once I have a little insight of, oh, it's this and not that, then now we're rolling. now it's, and I think we all know when that happens, what that's like, because it's like a very nice give and take and exchange. We're on the same page. We're collaborating. You got ideas. I got ideas. Oh, here's another way you might think about working on that. Now we're rolling.
And I'm going to stick with you, Reid, a second. Why don't you tell us a little bit about your new course, OCD in the 6-Moment Game, Strategies and Tactics?
Sure. It's 4-hour course. It's I think it's clever in terms of it's got a lot of mystery in it, and it's got some intrigue, and it's got some suspense, and it's got characters in it that you can appreciate and see yourself in them. My job in the 4 hours is to do what we're doing now. Start at, this is a mental health disorder. This is what it's doing to you. So I'm going to personify the disorder. This is what it's doing to you. And given that, here's how you need to respond to it. And so I'm going to lay all of that stuff out. So the metacognitive part of the work is that understanding and that comprehension. And the next step in metacognitive work anyway is, that's what we found out in all the research around kids and learning, is you must then have strategies. You must have strategies to implement the task. And so that's what I work on for the probably 2/3 of it, which is, okay, given we're trying to accomplish this, what kind of moves do we need to make? And as Sally's saying, it's basically principle based. There's only a few moves that you really have to be thinking about when you look at the really big picture. Trying to implement it can take a few little moves, but that's what we want to do. And I talk about the six moments, and I won't talk about the first 3 moments because those are kind of automatic, and that's what all of us have been talking about so far. But where I go in moment 4, which is the first therapeutic moment. So I've had an event, I've had a thought pop up, I'm freaked out about it, and so forth. The very first therapeutic step is a mindful detachment, just stepping back and going, oh, there it is, in one way or another, saying to yourself, oh, it's happening, or oh, I'm in it now, or there it is, or whatever. It is very much programmed with self-talk, verbal cues about what to do. And so I step back and go, oh, I'm doing it. Move 5, moment 5 is the position of I'm not going there. And whenever I talk about this, I can't help but have my hand move away. It's like, not going there, none of my business. Whatever I want to say to myself is, here it is. I'm not playing that game. And then I'm turning away and engaging in whatever I want to do instead of this moment. And I need to make moment 6, whatever I turn my attention away toward, I need to elevate it to be more important than my obsession or my urge. And I don't care if I'm tracking an ant colony walking across a sidewalk. I need to embed importance in that because I'm stepping away from this. Now, people will say, well, moment 6, that sounds like you're distracting yourself. You're not really doing exposure. Well, if you think about what we're trying to do, if the experience that I want to have is uncertainty, but I can make that uncertainty generic instead of specific. When my obsession comes in, like a question, what am I going to do? How's it going to go? And I don't answer that question. I move away without answering it. Now I'm doing pure exposure. I'm exposing myself to the feared thought without answering it or handling it. And that's the process. And so the course is all about the work that we do. Once we understand what we need to do, the work is always moment by moment. And what I need to handle is right now. Whatever's going on right now, how do I want my response to be? And that's how it's built.
I'm going to keep going, and then I have a broad question. Real quick,
Mike
Reid.
was applauding. Did you miss Mike's applaud? He was applauding. Yeah. Okay.
No, I know that. I just,
Okay.
who is the course for?
Well, it's for, everybody. It's fine for clinicians to, it's a protocol that people aren't familiar with. So if a clinician wants to add something to their repertoire and have a way, part of what it models for clinicians is how do you talk to the client? Because I'm one-on-one to the camera, to the individual, and that's how I'm addressing it. So it gives them a way to model it. And then for, clients, of course, it's a self-help course, and it's built for clients.
Thank you, Reid. And as you saw, Skyla put that if you'd like to buy the course, there's links in the comment section. If you put in IOCDF at checkout, you receive a 10% discount on the course. And also, Reid is so graciously donating 100% of the proceeds of the purchase using this code to the IOCDF. So thank you, Reid. Very kind of you. And please feel free to check out. I've been on the website. I haven't watched the course yet, but I've been on the website, and there's a lot of great stuff just on the website alone, and some great videos and things like that. So thank you, Reid. I'm going to get back to metacognitive in one sec. Sally, you have a new book out.
Yeah. There's a series of 3 books. Then the newest one is just out in the last month. It's called Overcoming Anticipatory Anxiety, and it addresses anticipatory anxiety, chronic indecisiveness, and catastrophic thinking. And it follows from the first 2 books. The first book was on unwanted intrusive thoughts. The second one is on compulsive reassurance seeking and checking, called Needing to Know for Sure. And this is the third in that sequence. That's the 3 levels of that we consider transdiagnostic, really, in the third one, because anticipatory anxiety is in, it's in all kinds of disorders, not just OCD. But we illustrate a lot of the points that we're making. This is with Marty Seif, my co-author of many years now. We illustrate a lot of it in the form of dialogues between 3 characters, and they march throughout all the books. First is worried voice, which is the what if, the intrusive thought, the worry, all the things that raise anxiety. The second voice in all of these dialogues is called false comfort, because it's all the ways in which we try to handle the anxiety that comes from whatever it is worried voice said. So it's reassurance seeking, checking, compulsions, avoidance, empty reassurance. I'm sure everything is going to be fine. Things that are done with the intention of reducing anxiety. And then the third voice is called wise mind, which could be called common sense. And these three characters march throughout the book, and in between are a lot of metaphors to illustrate points. One of the metaphors that just occurred to me while Reid was talking is that you're walking down the street and someone is walking towards you who is kind of a scary looking guy, an old raincoat, kind of limping, looks dirty, and you're going to cross paths with him. And right while he crosses paths with you, he says something to you really awful, disgusting, horrible. And you can't pretend you didn't hear it. So what should you do? And pretty much everybody knows, just keep walking. And you don't feel great for a while, but pretty much everybody knows that it's really not a good idea to turn to the guy and say, "What did you just say?" and get involved with him. So that's the metaphor we use for disentanglement. So the books, all 3 of them, have lots of metaphors to help get across the attitudinal and metacognitive shifts that we're recommending to people.
I love that. Well, congratulations. I saw Reid.
I just throw something in around, and I'll try to say this without getting choked up. But I've been colleague friends with Sally and with Marty for 30 years, and they are brilliant clinicians, and they make the complex simple. And I love knowing Sally and Marty, and I am so appreciative of what you're delivering in these 3 books. Great work.
And thank you. And you're one of my biggest teachers. So thank you for all those years of that. We also incorporate a lot of insights from a colleague of Mike and mine, who is Carl Robbins, who is just a brilliant thinker and is one of the people who's trying to bring Fred Ardema's IBT work into American OCD treatment. So I just wanted to mention his name too, because I consider both Reid and Carl my teachers, and Claire Weeks, my original teacher.
Well, thank you, Reid, and thank you, Sally. And for those of you that are interested, you'll see in the chat links to Sally's book, the particular one, Overcoming Anticipatory Anxiety, which will obviously link to the other 3. I'm a big fan of trilogies, so congratulations on your trilogy. I will talk to you later about the film rights.
That's enough.
What's that?
3
That's
is enough.
Too. We're stopping here.
Yep. Mike, what are you doing, man? What books, movies, courses? No.
Yeah. I'm not famous enough to do any of those things yet.
Yeah.
Yeah. No, I just stick to doing consultations and learning and nerding out on all things OCD phenomenology and treatment. So that's
may I say that Mike is one of the best consultants and teachers I know of, and he's got people coming to him for his insights every single day from all over the place. So he undersells himself.
Well, no, and absolutely, I've enjoyed my interactions with Mike on metacognitive therapy and the town halls that we've done, and Reid and Sally as well. We're closing in on time. I'm going to start this with Mike, and then we'll go around. What would you like to see in terms of metacognitive therapy moving forward in the future? It's long-term acceptance and integration into sort of, I hate to use the word mainstream, but mainstream treatment and therapy. Your arguments for pure behavior therapists that will be, the similar that we got the response when ACT first was like, oh, this is its own thing. Where would you like to see metacognitive therapy in its place in treatment and over the next 5 to 10 years? And I'm going to throw this out to all of you.
Yeah. So there's a couple of things I want to say, and I don't know if you're going to get around to us one more time for last comments, so I might be able to save some things in my last comments. But I would love to see metacognitive therapies of all stripes and kinds, whether it's inference-based therapy or the others, find their home in the IOCDF and the ADAA and the ABCT, all of the great organizations in the U.S. that are disseminating trainings and cultivating young therapists and young researchers. And so that we can sort of break down some of the tribalism that can occur between modalities and really offer our clients as many evidence-based treatment options as humanly possible. We know our therapies don't work for everybody and not all the time. And it's rarely the solution that we just say, work harder or come back when you're ready to do the work I want you to do. We want to make sure that we can, as therapists, be fluent in multiple languages, not just fluent in the language I prefer. That's where I'd like to see it happen. So maybe one day the BTTI could incorporate alternative to ERP and not just sort of complements to ERP, where it's like ACT plus ERP, but maybe an alternative in the years to come would be nice.
Thank you, Mike. I appreciate that. Sally.
Ditto. Couldn't say it better.
Reid.
Well, I'd love in 5 years or less for the field to be catching on to what we're talking about here, which is that the content, the theme, the topic is irrelevant to the treatment, not irrelevant to you, but irrelevant to the treatment. And if clinicians and clients and those working in self-help can absorb that idea and really bring it into the fold, I think that's going to transform the work.
Thank you, Reid. And I wasn't going to, but we have 3 minutes before I do housekeeping. And in case Mike was holding anything back, let's go ahead and do last thoughts anyway. Mike, final thoughts, anything you want to say?
Thank you. Yes, I would love to have last thoughts. So real quick, I think it's important for us to signal to clients that although uncertainty is involved in OCD, that I think we can help our clients get back to the same certainty they had before they started doubting. So much like you described your story about what if I beat myself to death with my fists, before you had that doubt, you were certain that that wasn't an issue to be concerned about. We can get you back there. We can get you back to a place before you started doubting. So this idea that you have to live with the possibility that you always could suddenly snap and beat yourself to death, I think in the here and now, we can get you back where you were before you started taking that doubt seriously. And if I could just do a real quick explanation of at least what I think is a good representation of metacognitive therapies, or at least inference-based therapy. And I'm stealing this from two friends and colleagues, David Carbonell and Carl Robbins, which is if you were to close your eyes and to imagine that you were in a movie theater and you were watching a revival of the Texas Chainsaw Massacre, and you're 45 minutes into this movie. Your palms are sweaty, you're on the edge of your seat, your muscles are tense, your heart is racing, your mouth is dry, and for just a minute, you are a teenager being chased by the killer. For just a minute, you're in danger. And then suddenly the person sitting next to you sneezes. And you are brought out of the movie and back into the movie theater. And in this moment, your muscles are tense, your heart is racing, your mouth is dry, and nothing is wrong. And you know nothing is wrong. And there's nothing to tolerate. There's no uncertainty to tolerate because it was just a movie. And you just became aware that it was just a movie. And what metacognitive therapy is trying to do is to create that sneeze for you. That's my closing statements.
That's my closing statement too.
And mine too.
Well, there you have it, folks. That's why Mike is an amazing consultant and works with Sally. Anyway, this has been a really phenomenal conversation, and I know that the community and everybody watching has been really, really interested and involved in questions and thoughts. And so thank you honestly for, well, thank you honestly. I don't know why honestly, a little tired, but thank you so much for being here. And thank you for sharing your wisdom and your years of experience and your insight on this subject. I remember when Mike brought it up, we did a Future of OCD Treatment Volumes 1 and 2 over the last summer. And we had Mike on with I think, I don't remember who was on that particular panel, and Mike talked about metacognitive therapy, and I got off of it, and I was like, I don't get it. That was literally my response, was like, I'm totally confused. And so I've been curious about it. So I was excited for this panel because between Reid's explanation and Sally's, just the simplicity, Reid hit it on the head. I haven't had a lot of time to talk with you, Sally, but the way you explain things so simplistically that it's so understandable, really complex topics in seemingly simple ways. Just the way you say stuck or sticky, it's very lovely. So thank you to all three of you for helping me understand what metacognitive therapy is. Clearly, if I understand it, I think everyone else will understand it as well. It's very exciting. At the end of the day, and I'm just going to say this is my own 2 cents, then we'll jump into it, is, I know that within this world, within the treatment community, there's lots of, conversations and divisiveness about which therapy and this, that, and the other thing. I mean, as someone with OCD, I'm super excited that everybody is researching and working tirelessly to come up with tools and skills and modalities of treatment that we can add to our arsenal, because there aren't enough, and that's really what this comes down to. It's not about one or the other. It's about like everything. How many skills, from pharmacologicals to invasive treatments and surgeries to modalities of treatment, this is an underdiagnosed condition. So many more millions are suffering than are reported, and by the NIH, and we need to do as much as possible. And I'm just so excited that we're discussing. I know, Sally, it's kind of been percolating since the 70s, but for all intents and purposes, this is new for us. And so I'm just so excited that we get to talk about another opportunity for folks that maybe ERP isn't effective for, or medication isn't effective for, that we have another path toward victory to regain our lives. And that's ultimately what this is about. So I appreciate you all, and thank you for that. Real quick, we'll just do some quick housekeeping. Again, you can check the comment threads for the links to both of Sally's book as well as Reid's course. Again, if you put in IOCDF checking out a Reid's course, you'll receive a 10% discount, and all the proceeds will go toward the IOCDF. So that's wonderful and much, much appreciated. Finally, I want to thank the IOCDF and Skyla for behind the scenes for the town hall tonight. Tomorrow is you can join Dr. John Abramowitz and IOCDF advocate Kyle King for this month's research roundtable. It's on psilocybin with Dr. Francisco Moreno, and you can submit questions and suggestions for future streams at iocdf.org/peace of mind. Also, registration is open for the 27th annual OCD conference taking place in Denver this July. We are so excited to be in person again and be back with our community. The special event for the entire OCD and related disorders community, including individuals, families, supporters, therapists. You can learn more at iocdf.org/OCDCon. Finally, you can join us for 1 Million Steps for OCD Walk this June and October. You can find a walk near you and register today at iocdf.org/walk for a day of community, advocacy, and fun. Finally, this live stream is one of many. You can see the entire schedule and submit questions and suggestions on future live streams at iocdf.org/peace of mind. You can view recordings of past live streams on IOCDF's YouTube channel. And if you want to be notified of all the live streams as they go live, you can follow on IOCDF social media channels, Facebook, YouTube, Twitch, LinkedIn. We're everywhere. We're just taking over the world. And most importantly, if you need resources, never hesitate to reach out to iocdf.org. Tons of amazing resources on there. Or if you want to reach out to the IOCDF, you can reach out at info@iocdf.org. I know we didn't answer questions today. If you have questions for Mike, Reid, or Sally, please feel free to email them to info@iocdf.org. Just put in the subject line, metacognitive, question for Reid, or question for Sally, or question for Mike. We'll make sure to get the question to them and get you an answer. So if you have a question, please feel free to email the IOCDF. Again, thank you so much, Sally and Mike and Reid, for joining us tonight. This has been a really awesome conversation, and I really appreciate you spending your time and humoring me with the role play. And just, this was really wonderful. So with all of that, thank you so much for spending your evening with us. Have a wonderful evening. Stay safe, stay vigilant, feel the feels. Don't let OCD off the hook. And we'll see you next time. Have a good night.